short, for MSS, especially metastatic MSS, outside of just the traditional chemo and some refractory salvage drugs that are not necessarily immunotherapy, immunotherapy has limited or no role for mismatched proficient or microsatellite stable colon cancer, which is a big unmet need. Even in the non-metastatic setting, for high risk, stage 2 and 3, after their curative intent surgery, it's just mop-up chemo. So there's a huge unmet need for immunotherapy-based options, because what's different about immunotherapy versus all these other buckets of therapies is, if your own immune system learns how to fight the cancer, these are the responses that are the durable, the long-term, the so-called, cure, the word that was started hearing it for MSI high, mismatch repair deficient tumors that were responsive to checkpoint blockade, years ago, even in the stage 4 setting. That's for MSS is still is an ongoing unmet need that prompted, and would be still an area of active investigation for companies and folks to come up with novel immunotherapeutic options for patients with mismatch repair proficient or microsatellite stable colon cancer. The Botensilimab and the Balstilimab, and often abbreviated officially as BOT and BAL, or BOT/BAL, two things prompted the design of this current study, NEST-1. One was that in patients with metastatic third line or patients who had already seen chemotherapy, Botensilimab and Balstilimab was showing promising activity, and interestingly, in patients who didn't have active liver metastases. So initially, the study started on a few years ago, where this drug for the first time was showing activity because it's a different type of immune activator. Often it's referred to as a multifunctional next generation anti-CTLA-4 antibody, as opposed to the traditional commercially available CTLA-4 inhibitors that are available. So this was in a highly metastatic refractory setting, was showing promise in about over 20% of the heavily pretreated MSS colon cancer. So that was something that caught our attention. In parallel, the folks in Netherlands, as well as in other tumor types, including melanoma and non-small cell lung cancer, there's something about neoadjuvant that is happening as a paradigm shift, where the same treatment, or especially immunotherapy that works in the adjuvant setting, works better in the neoadjuvant setting. So these two, ideas that were, or observations that were happening in parallel, prompted us to consider NEST-1 as what would happen if we had a study where we could use a neoadjuvant platform as the paradigm shift that has already happened, but use drugs that already are showing some promising activity in third-line metastatic setting, and see what happens, which is why we propose this idea as a investigator-initiated trial to Agenus to get funding for. Safety and feasibility actually was the primary endpoint, because you want to introduce, remember, these are patients who can get their colon surgery tomorrow or next week whenever the surgeon has time. I saw a patient a few hours ago. She could have had her surgery, this Wednesday, and we're saying do a few weeks of immunotherapy and then do surgery. So the last thing we want to do is do something that causes some sort of crazy inflammation or side effect that jeopardizes the curative intent surgery. So safety and feasibility of doing something neoadjuvant BOT/BAL in somebody who's about to get colon surgery was one of the primary goals. And we had met the goal because no surgery was delayed due to any treatment-related adverse events. Often, also as a design, we chose the lowest possible dose and only one dose of this BOT, because in the metastatic setting, the higher dose and repeated dosing, we know from experience that can lead to immune-related adverse events. So just to be cautious, we only ran with just 1/2 dose of what was the lowest possible dose that we thought at the time to do this, and only a few weeks of delay till surgery, so that we didn't jeopardize the curative intent surgery plan. So we only saw one person with a diarrhea and colitis that also was mitigated the same day, and the patient still had their surgery the following week. Interestingly, a lot of young females get this early immune activation syndrome, which is like exhibited by low-grade fevers and feeling a little fatigued. It happens the week off treatment, and it's not anything concerning. It's just, and it's also a sign that the immunotherapy is working, and all we do is supportive care in terms of just, NSAIDs or hydration or taking Tylenol or Aleve or Motrin. So that doesn't need anything special, and very seldom needs any steroids or anything beyond that. So safety was met. Now, in terms of what was provocative was we kept 3 patients MSI high just so that we had a comparison or a positive control arm, and 75% of these patients were MSS. In the MSI high, every single time there was no cancer found, and 100% of the time there was major pathological responses. In the MSS, if we look at major pathologic responses, and these are arbitrary shrinkage more than 50%, it was 67% of the time. And that was only within a few weeks of immunotherapy, so the big question that we had was what would happen if we let it brew longer, So the expansion NEST-2, by the way, this is perfect timing to be talking to you, that just opened 2 weeks ago, and we are just at our 5th patient about to start treatment this Thursday, and they're getting the exact same, 1 dose of the bot. The only difference is we're going to let immunotherapy brew for a little longer. So if we could see cancer, 100%, 100%, 90%, 85%, and several 50% just within a few weeks of immunotherapy for MSS, where the expectation is 0%, to see if that could be deeper. And then, this earlier talk about ctDNA is very pertinent to, even though it's a single arm study and a dozen patients, we just talked about MRD positivity, right? High risk, stage 2, 3. You expect at least 20, 30% of these patients to be ctDNA positive. None of them were ctDNA positive post-op. Everybody was negative. And negative at more than, now 40 time points with over 6 months of follow-up. So that's what's really provocative, is the fact that we would have expected at least one patient to have ctDNA positivity. And some of these patients were really bulky, big tumors. They went from like stage 2, not stage 2, stage 3C, stage 3B down to a stage 1. So even if there was 50% tumor kill, but if the final stage was a stage 1, we don't give chemo for stage 1. So that's truly downstaging, and maybe obviating the need for chemo in the future. That's a separate question that we'll try to ask in a bigger trial. But more importantly, I think there's a big unmet need to cure more patients. You saw the numbers. We just talked about Bespoke, that, if you're ctDNA positive, less than half of them are cancer-free at 2 years. So if we can increase those numbers by 20, 30%, and for that matter, like in this trial, in this results so far, nobody has recurred and nobody has ctDNA positivity. That's a very strong signal, which, any trial, the goal of that trial, okay, at least it should lead to the next trial. So that already happened as of a couple of weeks ago in February. So the goal of the next 24 patients that we're going to treat in a single arm setting, we did separate the MSI and the MSS because these are completely different beasts altogether. And for the MSI, we're going to give them the option of no surgery. So you could even do watch and wait and just do immunotherapy to hopefully cure you of your cancer, and no surgery might be needed. We have a lot of elderly folks with MSI high cancers who for example, may not need surgery. So we're going to ask that MSI high question separately. But for the MSS, we're going to see if the responses can be deepened by giving immunotherapy a few more weeks longer to brew. So in the NEST-1, we allowed surgery as early as 3 weeks into treatment. In NEST-2, we're going to allow surgery as early as 7 weeks into treatment. So that, would help us tell, if this promise is holding up. We saw also that the way your immune system was eradicating the cancer was kind of killing the cancer root up or inside out. So even when we found cancer, it was at the tip of the surface, and all the lymph nodes and like the bulk of the tumor, deeper layers, was negative. So that's the problem with our chemotherapy and surgery, is it's not the enemy that we see that's the problem. It's the unseen enemy that we fail with. So if your immune system can eradicate this unseen enemy, that's what's going to hopefully lead to more cures, which is why we're very excited about the expansion and how this bot-bal story is evolving in the neoadjuvant space with our NEST trial.